I thought we'll just, it's not moving. So I link understanding the breast cancer with imaging findings. So if you understand the pathophysiology of what happens, the changes that happen in the breast, particularly with neoplasia, and then go back and look at the mammogram, then the mammogram and ultrasound become more meaningful, and it will contribute more towards our treatment-related decisions and therefore improves the quality of surgery with better outcomes. So fundamentally, when you see changes in mammogram, the changes are because of structural changes that happen with tumor growing within the ducts and invading out of the ducts into the breast parenchyma, and it's all centered around the cell death, which results in calcification and surrounding host reaction. So the tumor changes in terms of what happens to the tumor that is growing. It undergoes necrosis, it undergoes cell death, and then that is seen as microcalcifications. And what happens surrounding the tumor in the way of host responding to the tumor is all the reaction that you see on the mammogram and ultrasound. So essentially, mammography is all about cell death, proliferation, and stromal reaction. Whereas fundamentally, I have not included any MR images here in this talk. In the future, sometime, let's go through some MR related images, and that actually adds a bit more to the perspective in terms of understanding breast cancer. Functionally, MR actually detects cancers because of contrast enhancement. So this depends on the local increased blood supply. So we know that tumor, for it to grow, needs blood supply, and this blood supply is all brought about by neoangiogenesis. Tumor itself makes new blood vessels. So this is seen as increased blood flow, increased microvessel density, and also the vessels that are formed newly by the tumor, facilitated by the tumor, does not have the normal vessel permeability like the regular vessels. So these are very leaky blood vessels, and because of this, when contrast is given, there is a sudden rush in the it results in vascular pooling. Wherever there is more blood vessels, the contrast tends to pool there, and because it also has leaky blood vessels, it leaks out of the blood vessels and results in more pooling there. And this leaky vessels is because of protease activity, because of the proteases that are produced by the tumor itself, and the increased blood supply is because of angiogenesis. So it's all about live tumor here, tumor that is actively growing, tumor that is actually leaking, and that is what is picked up with the contrast enhancement. And around this is the kinetics. So how fast does it pick up the contrast? How fast does it eliminate the contrast? So those are the type 1, 2, and 3 curves. And so functionally and morphologically, MRI is all about angiogenesis and protease activity, whereas mammography and ultrasound is all anatomical, centered around cell death, cell proliferation, and the host reaction to the tumor. So this is very important. Once this understanding is clear, then how you perceive and look at the mammograms and how it can contribute to your treatment-related decisions will be clear. So we all know this conventional pathology classification. We divide them into 2 categories. One is non-invasive breast cancer and invasive breast cancer. So non-invasive breast cancer is seen more in countries where screening is done more aggressively. So in our country, we do not have population-based screening, but however, we do have a fair number of non-invasive breast cancer. And oftentimes, it's not purely non-invasive and purely invasive. Invasive component will have some non-invasive component as well. So you often find reports that presence of ductal carcinoma in situ. So it's important to understand this for us to plan treatment. An invasive component can arise from the duct, can arise from the lobules, lobular carcinoma. So ductal carcinoma is the most common carcinoma. 90% of what we see is ductal carcinoma, invasive ductal carcinoma. And only 10% come under the category which we call as infiltrating lobular carcinoma. So in the ductal carcinoma, majority of what we see fall under this category of not otherwise specified, no particular feature documented. So some special types include medullary carcinoma, mucinous or colloid carcinoma, tubular and metaplastic. So these come under the special category. They account for about 10 to 15%. Majority are not otherwise specified. And then 10% are infiltrating lobular carcinoma. So this is the conventional pathology classification. So all this can be actually fitted into mammographic images that we see in a routine clinical practice. So where does it all start? So fundamentally, most of these start from within the ducts. So if you see the earlier in some earlier couple of sessions that we had, I showed you the images of how its breast tissue responds with proliferation and involution with each menstrual cycle, and that the TDLUs, the action place where things happen, changes happen. So assume that this is the terminal ductal lobular unit. So these little ones are the terminal ductal lobular units, and these are the major ducts. So somewhere here in the ductal component is where all these tumors arise. And if you take a cross section of these ducts, you see tumor that is growing within the duct, and this is what we call as ductal carcinoma in situ. And until the time it is confined by the basement membrane within the duct, it does not have access to blood supply and therefore does not metastasize. But if it breaches the basement membrane, then it comes out. Then is when we call it as invasive breast cancer. When that happens, it has access to both lymphatic and vascular possible routes of metastasis. So the ductal carcinoma, there are again the comedo and cribriform types. So what we mean by comedo type is if you look at the cross sections, this is a duct, and if you cut into that, you see that normally that should be lined by a single layer of cells, isn't it? That's what the normal ducts are made up of. Here there is heaping up of cells, and there is a lot of proliferation here, abnormal cells that are heaping up within the duct, and sometimes it heaps up so much that duct itself can distend and produce a mass. And you do have a component called palpable DCIS. A lady comes with a big tumor, you feel it, you see on mammogram a lot of calcification, you go and operate, and pathology says there's no invasive component at all. Majority of it is non-invasive component. It just bulges within the tumor. It doesn't manage to infiltrate the basement membrane. It's all confined within the ducts, but within the ducts it can go to bulge so much to produce a mass. And this is what happens. It keeps growing, it outgrows its own blood supply. So it cannot sustain itself within the duct and without blood supply. And so therefore centrally it undergoes necrosis. And this necrosis, actually this over a period of time calcifies, and this is what you see as calcifications, microcalcifications. So if you actually, this is the cross section of the duct, and you actually take the longitudinal section, cut, this is the duct, and you see how this brown bit is the calcific spots within the duct, and you see how it casts itself. Like you say that when snakes, actually in Tamil we say shatta urikkaradu, the snakes discards off its skin, and when you actually look at it, it's like a cast of the snake itself. It takes that shape. So similarly, calcification, that in that longitudinal tube, that tumor grows within it, the center portion of it necrosis, and that bit calcifies, and that calcification is what you see as microcalcifications, and that is in that linear distribution. If you see, they're all lying like in a linear line-like distribution, and it's not continuous. So obviously these things cannot continuously calcify, so there are breaks in between, and that is what we see. You can see that like little bits of pieces arranged in a linear fashion, and you could almost imagine that it's a tube, and within that tube all these things are lying inside. So this sort of a distribution, if you see lines like this and areas of calcifications that are not smooth, that they have some irregular jagged edges, and that is very typical classical of what we call as casting type or comedo carcinoma. So if it's actually like a comedo, because it's a dead tissue, it's like, you know, when you press out an acne, a little plug of dead material comes out, isn't it? So like this, when you actually cut into this and you squeeze, you actually see that white dead material coming out, and that looked like that comedo, and that's why it's called as comedo carcinoma. So this often has a distribution along the duct. So if you see this is a close-up view. So if you see this, the ducts are linear structures, isn't it? They're all tube-like structures. Of course, it branches out, but essentially they're all tubular structures. So if you see here, this microcalcification is linear. So these are all linear, or what we call a segmental. Within the duct system, it keeps growing. So if you see again this mammogram, and this is the nipple, and if you go backwards and look, the calcifications are, if you see again, this is a linear distribution. This is a linear, this typical Y form, it indicates that it's a branching duct. So it's all casts within the duct, and this kind of distribution is typical of a high grade linear branching calcifications. If you see this is definitely BI-RADS 5. This needs a biopsy, and this will need certainly surgical management, and this should not be ignored. So this is high grade DCIS when it happens like this. So pictorially it is like this. So a ductal system, it's not quite regularly arranged like that, but this is what I meant, segmental. So it goes back into the duct and it fills up within this duct, and that is what you see like this here. So and that is mammogram. And how does it look on ultrasound? So if you look at this, so ultrasound is very difficult to image DCIS, particularly very small areas of DCIS. You don't see calcifications on ultrasound unless it's a very, very high resolution machine, and you have a hypoechoic tumor within which you can spot some calcifications, but without a mass, DCIS, verum calcification, just calcification by itself is very, very difficult to perceive on an ultrasound. However, if you have an extensive area, a lot of tumor filling into the ducts like that, and obviously the ducts get bloated up, just like you see on the mammogram. Here, the ducts get filled up with that tumor, and you can actually see that again a linear fashion. You can, with the probe radial to the duct, you can actually see, follow the duct, and you see that the duct is actually filled with tumor, and those little white dots there are all the microcalcifications. This is actually the blood supply in this area. So another type, non-comedo type of DCIS is again, so the tumor grows within the duct again. This is DCIS again. In this, there is the necrosis happens patchily, not particularly only in the center of the duct, but again, like it is patchy, and also the tumor cells do not grow in a very organized fashion. It's very haphazard, and it does not fill the duct entirely. And then so this also can secrete fluid. So the cells lining the duct are secretory in nature, and the tumor cells also can secrete, and whatever fluid that gets trapped in between the cells petrify, and they calcify over a period of time, and this is what it looks like. So these calcifications are not organized as if it is within a duct that is growing along the duct. These are all kind of scattered. Again, the duct fills up to quite an extent, and these are all scattered and in a group, not scattered in the sense widely, but within that space in a cluster, it is scattered. And again, if you see, these spaces are not very organized and smooth. Benign calcifications will have smooth calcifications. The edge of the calcifications, if you see, will be very smooth. Here they're all jagged. Each one is of varying size, and they're all irregular forms. And if you imagine somebody crushing stones, and if you leave and you look at the pieces, remnants there, they all don't have one shape, one form. So they all different shapes. So this is what is called as crushed stone-like calcifications. And here what happens sometimes, you have papillary component, and papillary lesions are known to secrete, particularly micropapillary type lesions. They have fern-like extensions and they produce a lot of fluid, and this fluid secretes, and then the extensions that are protruding into the cavity often separate themselves from the primary tumor, and that also necroses and petrifies. So these also produce a lot of calcifications which are coarse, sometimes fine, sometimes coarse, and scattered over an area of lesion. So something like this. And if you see, they're all not uniform, they're all irregular and different shapes. So these are all what we call as crushed stone-like calcifications. Can you see that? These are all very fine, but this is a bit more coarse. And they're all confined to one particular area and may not have a segmental distribution. Here again, if you see, I don't know if you can perceive this, this is again a very linear distribution of calcification. So again, it's all taking the form of a duct. It's an early DCIS. And here again, you see these Y forms. If you see this Y form and linear forms like that, it's almost certainly, I mean, you don't need a pathologist to tell you that it is high-grade DCIS. So these kind of Y forms and linear distribution like this is almost always high-grade DCIS. Whereas low-grade DCIS may not take that Y-shaped distribution. It may look like a coarsely crushed calcification, a bit faint sometimes, and also powdery, as if somebody is actually sprinkled some powder on that area. So if you, I don't know, can you see it? Is it visible on the screen?
Yeah, clearly visible.
Yeah, so as if somebody sprinkled some powder here, and it is quite coarse, and it's not confined to one particular area. It could be quite widespread, and this is what we describe as amorphous, distinct, or powdery type calcification. So this, a good proportion of them are malignant, and these are often very low-grade calcifications. Actually, these are the types which may not actually change into invasive cancer at all. Whereas this would almost certainly become malignant. This is malignant. So this malignant, I meant invasive. So this would definitely have some invasive component. So, but whereas this low grade, something like this, are the ones that are overtreated because they may never become invasive. So classically, we used to use this Van Nuys prognostic index. Now we have prognostic tests like Oncotype DX to tell whether, see, the indication for all these tests would be after excision, who are the ones who will need radiotherapy. And some, if you've done a mastectomy, then it may not be necessary, and it's not necessary. But if you've done a breast conservation, so do all these patients require radiotherapy, or in some can you avoid radiotherapy? And so that is why we use the Van Nuys prognostic index to look at the risk of recurrence. And this particularly applies for patients who undergo breast conservation for DCIS. And so this Van Nuys prognostic index uses the score, which is given for size, margin, grade, necrosis, and age. So if the score falls under, so each one is scored less than 15 millimeters, 10 millimeters, 60, more than 60 years of age, and grade, and so each one of these are given scores. So score 1, 2, 3, and if you total it up, if the scores are between 4 and 6, then no further radiotherapy is required. But if it falls under 7 or 8, it comes under intermediate risk. 10 and 12 is again intermediate risk, high risk for recurrence. So these two categories will require radiotherapy, and the 10 and 12 may actually end up requiring mastectomy rather than just breast conservation. So this is what I summed up here. So excision alone for category 4, 5, or 6, score 4, 5, or 6. Excision plus radiotherapy for somebody who gets 7, 8, or 9. So this again, this information you will get only after excision. The size of the DCIS, margins you'll get only after excision. This is to guide radiotherapy decision after excision. So somebody who scores 10, 11, or 12, mastectomy would have been a better choice of treatment for them. If you've done breast conservation, it's good time to reflect whether to go back and complete a mastectomy on them rather than just radiotherapy. So now just looking at invasive ductal carcinoma, again we talked about this. Most of them come under this category that are not otherwise specified. So the 65 to 70%. Some of them are specific types. So it's good to know the specific types because you can prognosticate a lot based on these categories. So tubular is the best prognostic lesion. So this hardly does any damage. If you have a tubular cancer, particularly that is small, 1 or 2 centimeters, it rarely grows beyond that. So 1 or 2 centimeter tumors, these are all slow growing, strongly ER positive, HER2 negative tumors. It has excellent prognosis. So surgery, and sometimes surgery would, an elderly patient, just removing the tumor will suffice. So whereas medullary happens in young women, and they are usually high-grade lesions, often associated with BRCA. And contrary to the fact that they're all high-grade lesions, medullary cancers have good prognosis, particularly if they are BRCA associated. So, you know, we've been taught that, you know, high-grade tumors, young women are all poor prognostic lesions. But if they are associated with BRCA, treated well, medullary carcinoma, they have good prognosis, so they tend to do well. Mucinous again happens in older women. Again, it's a very slow-growing tumor. Tumor itself produces mucin, which is perceivable when you actually do an ultrasound. And you do a biopsy, you get very mucoid material, so this again they do very well. I mean, sometimes mucinous tumors, because of the accumulated mucin, the size might be very big. So you should not go by the size criteria to treat these patients with chemotherapy. So in somebody who's 60 or 70 with even 6 centimeter or 7 centimeter mucinous cancer, and they are usually strongly ER and PR positive and HER2 negative. And if you have a clear mucinous cancer, these are patients whom you can avoid completely chemotherapy. And don't go by the size criteria that it is 5 or 6 centimeters, and therefore recommend chemotherapy. If you do oncotype DX on these patients, they will almost always show low risk for recurrence. So these people do not need any chemotherapy. And again, papillary cancers. So papillary cancers, they are, again, you have the invasive papillary cancer and you have an encysted papillary cancer. The encysted papillary cancer, again, it's contained within that duct or the lobule. And this is, again, because it's encysted, it is not invading. It's treated like DCIS. But it may, because again, papillary cancers are quite secretory in nature, they produce a lot of fluid. So there's a big cystic component within these tumors. And because of that, the size may be huge. But if you have an encysted cancer or a solid type papillary cancer, these are all again good prognostic lesions, and these should not be treated based on the size. So this is why understanding the specific types is important in order to choose the appropriate adjuvant therapy. So breast cancer, again, it's not one cancer. It's very heterogeneous, and some of it are well differentiated, some are poorly, some are combined. And it's important to understand the heterogeneity of this breast cancer. Each tumor is different, and within the tumor, you have heterogeneity within the tumor itself. Intratumoral heterogeneity is also present. So it's important to understand this, again, to plan treatments appropriately, particularly adjuvant treatments. So if you look at, this is what we classically study, you know, if you look at, sorry, did you say anything? Okay.
No, carry on.
So if you look at a typical Bailey and Love understanding what we studied in our early days, we talked about skin-less cancers, isn't it? Something what we know of classically in a mammogram, spiculated lesion. So what is the spiculation all about? So the spiculation is all about the desmoplastic reaction that happens because of the tumor. So the tumor is there long enough, and because it's there for that long a time, it has the host, the normal breast tissue has enough time to respond in terms of a tumor being an antigen. there is a response to that tumor, and this the speculated lesions are very dense. The word squamous itself means very hard and dense. So the cellular component of this tumor will be very low, and so that the number of mitotic counts, the proliferation indices, all of this will be low. So if you do a Ki67 is a marker which reflects the proliferative component. So if you look at the Ki67 here, it will be low, it will be 2 or 3%. And my number of mitosis also will be lower, and so the grade will be lower. And so this paucicellular, meaning the cellular component is less, the collagen matrix is more, desmoplastic reaction is more, it's often low grade, and because it's dense, it results in shadowing on ultrasound. So because it's dense, it's tone-like, the acoustic waves do not pass through and go behind the lesion, and therefore there is a blackening out of the area behind the tumor. So what you see here, that bit is called shadowing. And when you put a Doppler, so we put your vascularity on the ultrasound machine, you may not see much because you expect when there is tumor, there's a lot of blood vessels. When in a squamous lesion, there may be just 1 or 2 twigs of blood supply in the periphery, but you may not see that florid number of increased blood vessels that you see with high-grade lesions. And there's a feature called elastography on ultrasound, which is one of the newer technologies. So elastography measures the tissue elasticity. So obviously normal tissue is elastic, and therefore, like the images that are reflected back on the screen, the vendor often have a way of measuring this. So what I use, there's 2 types of elastography, strain and stress. So it's all based on this physics principle of this Young's modulus. So I don't want to go into the physics, but it measures the elasticity of the tissue. So normal tissue is pliable and it's smooth, so there will not be any difference between the benign lesion and the normal tissue. It's often similar to that of the normal tissue. Whereas the tumor tissue, because of the host response, it becomes hard. The word squamous applies here. And because it's hard, the tensile strength in that area differs. And when you put the probe there, it shows a hardness. It measures the hardness. So when you compress, the yield of that tissue when it is soft versus hard is reflected back on the screen, and different ways of measuring it. In that machine that I use, it's called shear wave elastography, and it is color coded. So you know, and this is that it is a hard lesion based on the vendor driven coding. So this is one other useful method. So again, this is another squamous lesion. If you see, there are a lot of spicules, not as much as the other one, but there are quite a lot of spicules that you see. And ultrasound also, you see spicules that are radiating from that lesion. Those sharp angles that you see you can actually see that there as well. So whereas if you see, this is a very circumscribed cancer. So this is a circumscribed cancer. What I mean is that you see that margin between this and this, the margins are not smooth. There are that spicules that are extending beyond that lesion. Can you actually see? In fact, in this mammogram, if you see, it's like a breast within breast appearance. So you see one layer, one contour here and another contour here. That is because it is pretty, the speculation that you see is actually pulling that skin inside, that bit of the skin, and it superimposed, and it actually see that skin getting pulled inwards. So there is some skin tethering here. So that is a kind of because of the pulling action because of those spicules. And if you see this here, there are a lot of spicules. Whereas here, it's very smooth and it's very circumscribed. And here again, the matrix content is more. And the host reaction is minimal because it replicates so fast that it doesn't give enough time. It's not sitting there long enough for the host to respond with all these host reactions. And it's very cellular, so there's a lot of proliferation here. And if you actually do a Ki67 on this patient, it will be something like 40 or 60%. And it is often high grade and enhanced transmission. Again, the transmission, as I said, it depends on the when the ultrasound pass through, it passes through and through the lesion, and because of the fluid content, the hyaluronic matrix within the tumor, it is more, and because of that, and because of the cellularity, again, when there is more cellularity, there's more water content within the cells, and because of that, what happens is there is enhanced transmission. If you see, it actually lights up behind. It is more, the transmission is more enhanced, like you have fluid, and so these are all features of high grade lesion. And if you put Doppler, you see when there's so much of blood vessels and it's so actively growing that there is so much of blood flow within that tumor, and so therefore that this kind of a thing should immediately strike in your head that this is high grade, this is suspicious. This, although this looks smooth, oval, and benign looking, this is a cancer, and this has to be biopsy. The suspicion for a cancer should be very high. And if you put elastography here, again, because there is no host reaction, there is no hardness, and this a lot of fluid here, and actually if you this might be misleading here, because people might, if not for the fact that there is no blood supply, people may mistake it for a fibroadenoma because it's nicely smooth, marginated, ovoid, lot of enhancement. And if you put an elastography here, here is where they may not, this tumor may not show any hardness, and the elasticity, what we call is low elastic or a very elastic lesion. So then you may mistake it for a fibroadenoma and miss this tumor altogether. So this is why it's important to understand the basic pathophysiology of these cancers, to have this index of suspicion, and therefore biopsy and treat appropriately. And sometimes you have combined lesions. So if you look at this lesion, part of it is smooth, but part of it is spiculated. So this is what we mean by intratumoral heterogeneity. So you actually have part of the tumor that behaves like a triple negative tumor and part of the tumor that behaves like a ER positive tumor. And this is where actually sometimes do in one biopsy in one lab, you take a section in tumor tissue from here and do ER, and one lab will say ER positive, and some tissue from here and another lab will say ER negative. And the same lab you do on a core tissue versus operative tissue may have conflicting results. And everybody tends to blame the pathologist. But if the tissue is fixed well, and if you don't have any pre-analytic issue, then it is usually because of intratumoral heterogeneity. So this has to be accounted for when you look at your treatment-related decisions. So this is again another very nice, smooth-looking lesion, very innocent-looking lesion, and one might actually get tempted to call it off as a benign lesion. Like I said earlier in one of the talks, round is not reassuring. When something is oval, you might actually, relax a little bit. When it is round, like this, round is not reassuring. That is the word that you have to remember. And this actually was taught by Tom Stavros. I attended one of his course, and it's just imprinted in my head. Anything that you see round and solid, biopsy. No, until proven otherwise, take it as malignancy. And particularly with something as bright as this, with the blood flow, has to be biopsy. So these are again some speculated lesions, some examples just for it to imprint in your mind. So again, lesions like this with a lot of host reaction. Again, some combined lesions, and here you see some microcalcifications within this tumor. So it may have started off as DCIS that was high grade, and over time has progressed to an invasive cancer. And remember, DCIS does not go away. Once dead tissue calcifies, it remains there. Sometimes the tumor can produce proteolytic material enzymes that actually can liquefy the calcifications also. So disappearing calcifications over time, you have to take it seriously. You saw calcifications last time, but next time when you see there is a smooth soft tissue shadow, and then the calcification is gone, that means that is becoming invasive. It's producing material that is actually lysing those calcifications. So disappearing calcification, usually calcifications don't disappear, but if it is disappearing, it's an indication that it is becoming invasive. So these are some combined type lesions as well. Again, if you see, this could be a tubular cancer, a small tumor with lot of spicules, and if you biopsy this, it may show a grade 1 tubular cancer, and these are all very good prognostic lesions. This is to show that it can be multifocal or multicentric. You see within that small area, you see 3 different, maybe 4 different cancers. So all this has to be looked at carefully in a mammogram, because planning, if the radiologist doesn't mention it, we should be able to figure it out and offer treatment accordingly. So if you miss this or miss this and end up just treating that, then with the breast conservation, then you could end up with a it won't be called a recurrence, because you never remove the tumor fully in the first place. Again, this, as a surgeon, this part is important. This tail-like extension, this is what in mammography we call this comet tail sign. So this is the lesion, but if you don't look at this, and you actually, this is a nice circumscribed lesion, small lesion in a good sized breast. This is an ideal case to preserve the breast, do a breast conservation procedure. But you have to factor in this tail, because this will have some invasive component as well, or even a DCIS component. And if you miss this, and just because on table we'll only go by palpation, and if you remove by feeling this, if you remove that much, and if this is just a few millimeters, you may actually miss it, and that will be focal positive. And if pathologist also misses it on margin assessment, we know they are only accurate to about 60%, and even in the best of pathologists. So if this is missed, this is the case for local recurrence. So on ultrasound, you see it like that. So with the tumor, you see that little tail that goes beyond the lesion. So this little 2 or 3 millimeter extension should not be missed when you're planning breast conservation. So this is again ultrasonologically tumor that is irregular in its margin, taller, hypoechoic, and again it has enhancement behind, and these are one of those tumors that are likely to be high grade. So this is for a lot of speculations and host reaction. You see that little bit of brightness around the tumor. That is because of a peritumoral response, lymphocytes around the tumor, and these are likely to be Skivers low-grade lesions. And again, to show that ultrasound, they are irregular, hypoechoic, and with irregular margins, taller than its wider. So various ultrasound. So again, this is a typical low-grade lesion where you see a lot of host reaction, and it's darker behind. With all this brightness around this lesion, this is what we call as echogenic halo. This echogenic halo means the host is responding to this. This is in contrast to the halo that I described in mammogram. That is benign, but this is malignant. And here, this is a high-grade lesion. Why high-grade? Because it's growing so fast that it is actually necrosing within, and you see a mixed echogenic area, an anechoic part within the tumor itself. It's taller, it's bright behind, which means the cellular component is more, and because it's necrotic also, so there is enhancement of what we call as acoustic enhancement of this, and that is usually indicative of a high-grade lesion. And again, grading is assessed by tubule formation, number of mitosis, and nuclear pleomorphism. So this is, you would often read in the pathology report, Nordica modified system of Blumen-Richardson grading system. So these are the 3 factors by which they grade. And low-grade lesions, like I already told you, are like this, spiculated lesions, which lot of speculations like this. These are the typical low-grade lesions, whereas high-grade are more circumscribed and very, very little post-reaction surrounding. And again, on ultrasound, it looks like this. I keep showing a lot of images because again, you keep seeing a lot of images, it gets kind of imprinted in your mind. The next time you look at an image, you look at it with a different vision, and it's just no longer reliant on a radiologist to tell you what to do. So this is the low-grade lesion. If you see just a little speck of blood vessel here, but other than that, like irregular, a bit of host reaction and shadowing. Whereas here, it is a tall lesion, circumscribed margins, and what is happening is it's very bright behind, and because it's solid and bright, we often, and it's taller, we biopsy, and this is usually a grade 3 invasive ductal carcinoma. And look at this. This is how high-grade lesions look like, and this is how low-grade lesion. Very little blood supply, But here there is a lot. You put a Doppler, color Doppler there, it just like lights up with so much. It's going so fast that it needs so much blood supply, and it actually makes its own blood supply, what we call as neoangiogenesis. And because it's outgrowing its blood supply so fast, it also can necrose in the center and sometimes in the periphery too. And this is important. I talked about it last time when we did the core biopsy lesson. Here, this is important because there's only a very small rim of tumor tissue. And if you do an unguided core biopsy, this is often a palpable lesion, okay, so and you put a needle into it, your needle might actually strike this part where the tumor is already necrosed, and the pathologist is just going to tell you that it is necrosed tumor, and then you don't have a clear diagnosis, which is why even though it is a palpable tumor, it's useful to actually do an ultrasound guided core needle biopsy. So this again, you see how this. So this is the whole lesion, and how this part alone shadows. So this is the fluid. Necrosis is liquefaction, isn't it? Liquefied necrosis. So it's more fluid content. And if you look at it, see how nicely you can actually see the principles of physics here, ultrasound physics. So this part where there is fluid, there is acoustic transmission. So the sound waves actually enhance more, and that is why it's brighter behind. Whereas this part is more solid, and you do see, I mean, it's not shadowing definitely, a little bit of enhancement, but you can actually see the difference between where there is more fluid versus more solid area. So another thing is Lebowski's law. So this actually, quite often you have patients coming back and asking you, so the mammogram will give one size measurement, ultrasound will give one size measurement, and then I go and do surgery. Surgery will give a different size measurement altogether. And actually imaging underestimates the size of tumor. Imaging, so palpation and on imaging, the imaging and clinical examination, there's poor correlation. What we see in clinical examination, we call it as 4 centimeter tumor or 5 centimeter tumor. In fact, in a scabrous lesion may only be a 1 or 2 centimeter tumor. But imaging and pathology, there's usually better correlation. But this, what we call is this, go back and read what is Lebowski's law. It's something to do with the actual size correlation. So the tumor is, the measurement is different in different modalities of imaging. So in MRI it may show something, in the CT images of the PET will show something, and in mammogram it will show something, in pathology it becomes something else. So this confuses the patient, and quite often in practice, particularly in our type of private practice where patients read through every line, whether they understand or not, and they only can figure out few things. And they come and say, suppose you end up waiting a week or 10 days for surgery. It may just be a week or 10 days, and within that period it's not going to increase in size that much. But they often panic. Because we waited that long, this grew this, became this on pathology. So all these kind of confusion exists in their mind. And sometimes, clinicians are not able to explain to them clearly. And this actually is useful to understand them because each one measures different aspect of the tumor, and what we see on imaging is not always what pathology tumor size does not correspond, and for treatment related purposes, what we see on pathology is what finally matters. So some specific types now we see. So this is a medullary cancer. Like I already said, medullary cancer is high grade, occurs in young women, and it's usually associated with BRCA. And these are the tumors that get waylaid as fibroadenoma, because one, it occurs in younger women, and fibroadenomas are more common in younger women, and so it gets labeled as fibroadenoma and gets missed. So this has to be, you have to have a very low threshold to biopsy, and they should not be missed, because these are the tumors that are likely to do well, in spite of the patient being young, and in spite of the patient being high grade, and usually triple negative also. These are subsets of that triple negative that do particularly well, and their overall survival is very good. So these should not be missed. So again, another example of medullary carcinoma, very smooth, nice looking lesion. And if you see, again, very circumscribed and very cellular tumor, some blood supply within, and it's also enhancing. So these are all enhancement. All this is a feature of benignity, and high-grade tumors also show that. But one should not miss these things as fibroadenoma. So this is a much older woman. If you see, it's a very fatty breast and a very circumscribed small lesion. And if you look at this, this is again nice and ovoid and very benign looking lesion. But in a fatty breast, if something looks like this, you can have a high index of suspicion for a mucinous tumor and biopsy it. And actually, if you look at this, lots of mucin within the tumor. Looks benign. These tumors, again, they tend to do well. This is an ideal situation where you can do a breast conservation. And if she's over 60 or 65 or 70 and it's a grade 1 ER/PR positive mucinous cancer, she may not even need radiotherapy. She'll do well with just a simple surgery. And this is an exception, of course. There's no radiotherapy for breast conservation. Rule applies for very select patients. So one should not go with that idea that you can for general idea. So again, another mucinous cancer. If you look, so this itself, within this, there's a mixed density here. So there's a high density area and a slightly low density area. And this is because of the fluid content within the tumor. And if you see here again, there's areas like spaces of mixed echogenicity and lot of enhancement behind. And this is a classical mucinous tumor, and you put a needle into it. It's often difficult to differentiate sometimes from a triple negative on imaging. But when you put a needle into it, that mucoid substance that comes, you know that it is mucinous cancer. And pathologists will confirm that. And these are tumors that can be managed conservatively, and she'll have a very good prognosis. And so this is a typical tubular cancer. If you see, it's a small tumor. It takes a long time to grow. So this is a tumor that if you see this year and you don't treat this year, even if it is missed on a mammography, 1 year later, if you come back, it doesn't grow very much, and it just remains more or less the same size, or a little growth, if anything. And these are, you see some spicules here, and you can actually see the spicules very nicely here on the ultrasound. You can actually see it nicely radiating from the tumor. So this, and it shadows a bit also because it's there for a long time. So these are tumors that are typically grade 1 ER/PR positive and low Ki67 and HER2 negative, and these also can be treated conservatively. So this is what we call as a papillary cancer. So look at it. It's a large mass, but that large mass, the tumor actually is only this. This is all the secretory component. So the tumor produces this fluid, which actually stretches it and produces this large mass. So going by the size criteria, and because it's large, we should not end up giving them, over-treat them with chemotherapy. So this, the size criteria here does not apply in the classical sense. That is why the new HSCC staging, 8th edition, has actually factored in the biology of the disease as well, the grade, the ER/PR status, and they've incorporated prognostic tests like Oncotype DX, MammaPrint, etc., into deciding the further treatment, whether adjuvant treatment is required. So if you look at this, this is the invasive component. This is the malignant. This is the tumor, solid tumor. This is the cystic area, and you put a Doppler there. See how well it lights up within that area. So that is the growing component, and so obviously we have to remove the entire thing with the clear margin. So this patient will end up requiring a mastectomy. But quite often, considering the size, one might think that it's a poor prognostic lesion, but actually it is all dependent on this. So the grade of this and the ER/PR status, and quite often papillary carcinomas behave well, and they are low ER/PR positive tumors, and many of them are encysted, and encysted behaves like DCIS, meaning that they do not invade. But there are invasive papillary carcinomas also, but stage for stage, invasive papillary carcinomas behave better than invasive carcinomas not otherwise specified. So this is an example of encysted carcinoma. Again, you can see the difference in density. So the solid component versus the liquid is even perceived on the mammogram, 2 different densities on mammogram. And if you look at the ultrasound here. So very nicely you see that this is a tumor surrounded by the secretory material, which actually is reflected as a increased size. So if you see, that is the tumor, and there's some septa-like thing growing into that cyst, and it's producing that fluid which kind of encysts that whole thing, and one wall alone it will be attached to that cyst wall. So do we have time? I think we're close to 7.
No problem. We can carry on.
So you don't have anything scheduled after this?
We have next one is at 8 o'clock. Carry on.
Okay. So the next thing is the lobular cancer. This is a radiologist's nightmare. Or maybe actually we should split it up into another session because there's quite a lot coming behind. You want to do it in another day?
Yeah, I think that'd be fine because it's an hour already, and you must also.
Maybe we can discuss.
It's tough for anyone to take, as a matter of fact.
Sorry?
It's too much for anyone to take in one go.
Okay.
One more session.
Maybe we can just have a few minutes of discussion, and I can do this again in another session because there's quite a lot more.
Okay.
Lobular cancers require a bit of attention.
Continue tomorrow, same thing. And we'll open the thing for questions now.
Yeah, 10 minutes because I have some other thing to do.
Okay. Josefa, what is your question?
Yes, sir. Ma'am, can you just explain once more the difference between low grade and high grade DCIS on mammography?
Yeah. So low grade obviously, grade is dependent on tubule formation, number of mitosis, and the degree of nuclear differentiation, isn't it? That's what we call as nuclear pleomorphism. So this grade depends on this actually depends on the number of mitosis is the proliferative index. So if the proliferative index is high, that means the tumor is dividing more and more at a faster rate. So that is what it's also indicated by the tubule formation. So when this happens, when there is more cellular proliferation, then it keeps growing and the tumor becomes manifest clinically and becomes more apparent before the host can respond to it. And so therefore, there is not much host reaction. Surrounding the tumor, if you see the rest of the breast tissue in the neighborhood, there is not much host reaction. So the lesion tends to be more circumscribed, more rounded. And
so ma'am, usually high-grade DCIS, they are usually more circumscribed?
Separate DCIS from invasive cancer. DCIS,
mostly?
Keep that separately. Now we're talking about invasive cancers. So invasive cancers, when they are high-grade, they do not produce any host reaction. So the tumor tends to be more rounded and more circumscribed. So these are the tumors that are growing fast. They tend to be ER negative biologically, and they tend to be high grade because there is more mitosis, more tubule formation, and because they are proliferating and growing rapidly, they have more blood vessels and host reaction is minimal. Whereas in low grade tumors, the number of mitosis is low, so therefore lesser tubule formation, and cellular differentiation is better, and because it is staying there for a long time, it grows over a period, it takes its own time to grow. The host has enough time to recognize it as tumor, and it produces some reaction around it, and that is what you see as spicules. So the low grade tumors tend to be grade, and they tend to be strongly ER positive and very little blood flow into it, and low proliferative index. If you do, you do ER, PR and HER2, now most of the treatment related decisions are also done with estimating the proliferative index, what we call as Ki67. So if you low grade tumors will have a low Ki67. This is the reason why, because the proliferative component is less here. Whereas high grade tumor keeps multiplying so fast that the host is overwhelmed, and before they can produce any reaction, this produces a mass. And then they come to you clinically. And you do a biopsy, there's more cells, more mitosis, more tubule formation, and more blood vessels. and this is what we see as high-grade tumor. So this is invasive component. Whereas in DCIS, again, DCIS here, because when the tumor in high-grade tumors, so what it does in DCIS, remember the tumor is confined within the ducts.
Yes, ma'am.
Ducts have a branching pattern, and the tumor is confined within the duct, and within the duct it bulges. So it keeps growing. It does not penetrate the basement membrane, but it needs space. No, it keeps growing. So I imagine that it is bulging the duct is bulging to accommodate the tumor, and it also grows within, and it keeps growing within the tumor. It's like, you know, like the thrombus in a blood vessel. So it keeps progressively keeps increasing along the blood vessel, along the entire length of the blood vessel, isn't it? The thrombus in the deep veins in the cuff, right, goes right up to the IVC within the vessel. So something like that. This within the branching ducts, the tumor keeps growing, and it casts itself. That is what, because it necrosis, the center part of it necrosis, it casts itself. The calcifications appear like casts when you look at the mammogram. So it bulges like that, and then it casts itself, which is what you see as these Y forms. It takes that shape of the duct and the distribution of that duct. So it is segmental, it's linear, and it's branching like the ducts branch. So these are often high-grade tumors. Whereas the low-grade ones,
okay,
a little bit, it just changes here and there.
Satisfied with the answer. We'll go to Dr. Amaravani. What's the question? Madam?
Dr. Selvi, very nice presentation. I learned a lot today. I just wanted to ask you, showed one picture in mammography where it appears like a benign, but there is a tailing or the extension like an EDA branching. Yeah. You were specifically mentioning that you will have to remove this tailing part so that the invasive part can also come in and the pathology will be complete. Yeah. Do you do any intraoperative ultrasound for a needle localization to remove this tailing part?
No. If it is palpable, then you don't need a needle localization at all. And
okay.
That is why you study the images beforehand, and you know it towards which direction the common tail extends or the duct extension is present, and you actually, with good high resolution ultrasound with good magnified images on mammography, you can actually see the entire length. And to that extent, if you clear, and to that volume, if you can remove and still ensure a clear negative margin on pathology, then conservation is optimal. I can show you some images later. Tomorrow's thing, I'll show you some images where we've done that. But otherwise, if you cannot ensure that, then a mastectomy. Intraoperative ultrasound is useful, but I personally do not do it. And it is very, very challenging. It's very, to put the probe, the sheath, and you have to be very conversant with images on otherwise to be actually able to do intraoperative ultrasound. And to me, because I have a very good understanding of ultrasound and mammography, I can visualize it three-dimensionally, and if I plan my surgery properly with the appropriate ultrasound and mammography images, for me, I don't think personally ultrasound adds more value intraoperatively. And again, when I do these kind of excisions, I may do a specimen mammography and sometimes a specimen ultrasound if I need more clarity. But intraoperative, it can be done. There are people who do it, but to me, it is redundant.
Okay, fine.
Any more questions? Any more questions? If there are no more questions, thank you, Dr. Selvi, for such an extensive coverage of understanding breast cancer. We'll see you again tomorrow, same time, or maybe earlier. Thank you.
Yeah, let me know tomorrow. Yeah, thank you. Bye.